Thank you. Good morning, everyone. I'd like to call this meeting of the Cook County Public Health and Human Services Board to order on this Tuesday, March 18th at 8:30 a.m. First item is the approval of the consent agenda, which includes our meeting agenda, the minutes, financial report, abstracts and bills, and the renewal purchase of service agreement with AEOA for employment and training services. Is there any adjustment to our agenda, or is there an item the commissioner would like to pull from the consent agenda?
Mr. Chair, I'd like to move to approve the consent agenda as presented.
Thank you, Commissioner Sullivan. We have a motion. Is there support? Support. Thank you, Frank. We have a motion and support. Any further discussion? Hearing or seeing none. All those in favor?
Aye.
Aye. Opposed? Motion passes unanimously. Thank you. Moving on to our staff report. Got a whole crew here this morning. Andrea Orest and Leave Thompson and Andrea Tofty and Rocio Rivas are all here this morning to present on opioid-focused prevention, treatment, recovery, and risk reduction.
Good morning, everyone. I'm Andrea Orest, public health educator with Cook County Public Health.
And I'm Leave Thompson. I'm the outreach coordinator at Sawtooth Mountain Clinic.
And we collaborate with Grand Portage Human Services and Grand Portage Health Services and a number of other entities under this Rural Community Opioid Response Program grant. So today we're going to talk a little bit about the reverse site visit that we attended in Washington, D.C. for the grant. And then we'll talk through the poster that we created for the event. And then we'll do a little bit of tying it more into a national level with the other two attachments that were in the board packet. And then talk about sort of future initiatives from the RCORP grant and other potential funding sources to continue working on prevention, treatment, and recovery. Okay, so we attended the reverse site visit in Washington for the HRSA grant. It's Health Resources and Services Administration. And so we work under the Rural Community Opioid Response Program Implementation Grant. So we attended the reverse site visit where it was a lot of different breakout sessions, but then also grant-specific sessions, and then we presented our poster in the grantee showcase. So that's our poster that we presented. Let's see, we attended different breakout sessions on medication-assisted opioid use disorder treatment, crisis response paralleling substance misuse concerns, youth involvement in prevention, and youth substance misuse treatment initiatives. Those were the ones that I could think of. We went to a lot of things. One of the more memorable points for me was sort of the reminder that in relation to substance misuse, the only bottom that really matters is death. And if a person has a chance to stay alive, then they have a chance to recover. So when we talk about risk reduction and secondary prevention, you know, really helping people stay alive to have that chance to recover. All right, so that's sort of a rundown of the event. Do you have anything? Oh, keep on talking.
Any questions from anyone regarding the event or trips? This poster is chock full of info, so
Well, it was really big.
Yeah, okay.
It was really large. It was like larger than the painting behind you. It was large. We tried to bring it home, but
wouldn't fit on the plane.
It wouldn't fit in anything.
We also, compared to the other posters, a lot of them were very specific projects, and ours was one of the few that was this like big sweeping county-wide initiative, which I think is cool.
Any of the specific projects stand out I mean, I guess you mentioned a takeaway from but just looking for other angles, I guess, or do you feel like there's a lot more value with the broad sweeping, or I guess it's different for every community, so.
Yeah, I mean, I would say this won't surprise you, but we're one of the least dense counties. And so a lot of the other projects just don't fit within our county. We don't have those like really, substantial yet micro communities to work with.
Sure.
There's like demographics that people are really focusing on. So for us, it makes the most sense to do a grander scale just because of our population size and population rate.
Yeah. Commissioner Gamble, you had a question?
Yeah, thank you, Mr. Chair. I was just wondering if there's any discussion with all the breakout sessions that you had related to the opioid problem and its origins. I mean, that's sort of a broad stated, but when we look at it, if we find that it's something that we as individuals make choices for recreational or whatever, as opposed to if it's coming through what we would consider to be a trusted agency that is using it as a means of helping somebody in their wellness, that understanding that it changes our methodology so that we aren't creating a problem of addiction, so to speak.
Yeah, there were not any breakout sessions specifically speaking toward the origins. In some of the breakout sessions, the presenters talked about sort of where we're at in relation to the origins and how, the overdose deaths are going down on a national level and in most state levels, but nothing about sort of the origin, at least not any that I attended.
Yeah, there were no sessions specifically about that. When the clinic started we call it medicated assisted treatment program. Likely that term will change to be more with the times. But when we started that, the providers that started it did discuss that the medical community had a lot to do with it and overprescribing pain medications. There has already been a big shift in the medical community to address that and to tighten up on how they prescribe those medications. You could say the harm has already been done, but because there's just so many, fake opioids out on the streets. But from the clinic's point of view, the reason they wanted to start this program was because they felt like they had a responsibility as the medical community to address a problem that the medical community had already caused.
Thank you. And I think that's important in anything that we're facing is understanding, where did it originate and are we contributing to that or not? So an assessment means we have to step back, and I appreciate your comment relative to taking a look and feeling we have a sense of responsibility in this regard, but I know that the over-prescribing, but the whatever that is a driver that becomes our practice, understanding where did that originate, just helps us to learn in the future. We have to be careful that we're not opening up a Pandora's box, so to speak.
Yeah.
Thank you.
Yeah, Commissioner Storley.
Thank you. A few years ago, when I was at one of the NACO conferences, the opioid cases in southern Ohio and northern West Virginia and all that were just sky high. And now what's happened is the drug companies are being taken to task because of what they have promoted. And I don't know about all of us, but I know at times when a person is giving an opioid because of surgery, a lot of my friends say, I take one the first night, and then I don't do any more. I've been given 5, but I only do 1 because I just don't want the repercussions of what I could get addicted to. So, but that's an adult. I don't know, if a younger person would look at it that wisely. Yeah. But anyway, thanks for being here to work with it in our local area.
Yeah, Frank, please.
Thanks. I'm going to take the opportunity of having our experts here, our MAT experts here, to ask a question. At the last advisory council meeting, we got a lot of information about Medicaid. And one of the items talked about how Medicaid covers half the substance abuse treatments in the state. But one of the things that it said was most people who enter drug and alcohol treatment complete it and are successful in reducing or eliminating their substance use. I guess it depends on what you call successful. My understanding is people who complete a drug rehab program, and I think that's what they're talking about here, residential drug rehab programs, typically about 10% are successfully staying sober for 5 years after the first treatment, and after they go back again, many do, like 10% will be sober after 5 years from the second treatment, and then 10%. So each iteration, basically another 10% can stay sober. That seems like a huge difference between that and saying most are completed and are successful. Again, depending on what you consider successful. Do you have any data on evaluating the effectiveness of MAT in the longer term?
I don't have it with me. I have, a brochure for the clinic that has that information in it.
Okay.
I would say with MAT or MOUD, the idea is that the patient will stay on, in our community, it's Suboxone. They'll stay on Suboxone. We like to think of it like you would think of insulin for diabetes.
Mm-hmm.
It's not something that you're going to slowly wean yourself off of. The idea is that they'll get to a nice stable dose, and that will help them maintain, hopefully, sobriety for the rest of their life.
Okay.
Yeah.
Thank you.
We had a really great plenary who talked about his recovery journey, and he talked about relapsing and trying not to think of that as an unsuccessful attempt, but just part of that recovery journey, and it's going to look different for everybody, and I really like framing it that way.
Right, and I don't know how Medicaid would define successful exactly, but when we talk about a successful recovery, it really is defined for the person. So they are going to define what their success is. If it's abstinence, if it's, if they're using 2 substances and now they're just using 1, or staying alive sometimes is the success. So really looking at it from the individual's lens so they can define what their recovery looks like.
Thank you.
Yeah.
Great. Well, sorry to interrupt if we were going to go on to the next slide, but
That's
thought we
okay.
should
Ask all the
have
questions.
questions here for this poster.
Okay, so next we'll sort of go through our poster a little bit, and part of the reason that we chose this was because it, gives the broadest overview of the last 4 years of this grant. So because this was a national presentation, we included some background information on Cook County. So I'm not going to read all of our background. You can read that. But the objective of our grant is to build the capacity of the Grand Portage and Cook County community to provide their own culturally relevant evidence-based prevention, treatment, and recovery programming and services using a community partnership framework, building on existing resources in the community and expanding current partnerships. So what we looked at was, really taking the valuable partnerships that we have in Cook County already from previous initiatives, including COVID, and building on those to create better prevention, treatment, and recovery resources, or more comprehensive. Our consortium members are listed there. There are a lot of them. I'm not going to read them all out, but they're, our local schools, Grand Portage Health Services, Grand Portage Human Services, Oshki. We had some regional partners like Harm Reduction Sisters out of Duluth. and all those other ones.
I got a Sue Purchase, is that a,
Yeah, so that is, Sue Purchase is the Director of Harm Reduction Services.
okay.
And when we went through our draft versions of the poster, we had to take all of the words harm reduction out and replace them with risk reduction because of the federal mandates that came a little while ago. So we were trying to figure out how to properly represent, the collaboration that they did, but we couldn't put their name on the poster.
Thank you.
So Sue Purchase from Harm Reduction Sisters. Yeah,
Awkward. No.
right? Yeah. It was, yeah. So let's see, the major goals are to expand culturally appropriate and evidence-based prevention programming for youth and community members, build infrastructure and capacity for evidence-based and culturally appropriate treatments, strengthen the network of non-clinical supports to individuals seeking or living in recovery, connecting them to tools and resources in the community. So under the grant, I acted as the prevention coordinator, and Leave acted, I say acted like it's over. It's not over. Acts as the treatment coordinator, and then Mike Flatley from Grand Portage Human Services was the recovery coordinator, but he's transitioning into a new role. So, but throughout the bulk of the grant, Mike was participating as the recovery coordinator. Some of the progress that we made, so in the sort of realm of risk reduction and prevention, we chose they wanted to have some data on the poster, so we chose to highlight some of the naloxone kits, Narcan kits, the leave behind kits, and fentanyl test strips that we distributed in the community. The initiative on community members being trained in Narcan or naloxone administration, our initiatives around youth mental health first aid and adult mental health first aid, and then the prevention programming and supports that we provided to schools and local youth groups. So some of those examples are we supported with the funding for this grant directly under prevention. We supported youth programs like North Point, youth passes to the YMCA. We supported some school summer events like canoe trips, the LGBTQIA 2S plus youth group. And then we also did some larger initiatives around stigma reduction in media, where I met with the different media outlets and sort of provided them information on how to talk about treatment, prevention, and recovery without being further stigmatizing. And then if you've seen the giant billboard coming into town for 988, that wasn't funded by our court, but it was born out of the our court initiative. And that's part of a larger campaign that we are sort of working on called Be There. There's a portion of the public health website that is devoted to ways that we can support each other or other people or youth specifically. Let's see, some other initiatives under the prevention and risk reduction are the overdose prevention kits inside the county buildings. We've done a fair amount of community outreach and education via the different media outlets, and then school newsletters and student survey data presentations. So when the last round of Minnesota student survey data came out, I did a presentation on that data for our local area. And now that the schools are just completing the new round of surveys, so in 2025 there will be new data around that. And then for youth mental health first aid, we were able to use some of our funds to get 2 school staff locally trained to teach youth mental health first aid. So we're working on building the capacity for them to be able to provide that training more often in the community instead of having to bring trainers from outside the area. That's prevention.
Yeah.
For treatment, we expanded our MAT services. So there used to be a waiver that the providers had to get in order to prescribe Suboxone. That waiver was waived in order to make it easier for providers to start, working as MAT providers, just because it is so successful. So we went from 2 providers to now we have 4 providers working within that program. We also expanded services to Grand Portage Health Services to remove that barrier for people. So Dr. Sampson, who does a lot of the work up in Grand Portage, went to the tribal council and spoke with them about the program and got that approved. And our MAT program has grown from 11 to 17 enrolled patients. We did some interviews just to find out how people felt about the program, things that we could do to improve. We've created more resources that they get upon starting. Our program's a little different. We don't have a lot of patients coming in crisis. It's a lot of people transferring from a treatment facility or from another Suboxone program. So we have a relatively stable patient demographic. But we've done some work with the Native American Community Clinic in the cities. They have a very robust program. And they've met with our providers a couple of times just to talk about how they might deal with patients coming in more of a crisis, people who are maybe still actively testing positive for fentanyl, and how to get them started successfully on Suboxone. So, yeah.
So when we look at the recovery progress, a little weird because, Mike's not here to present the work that he did, but we wanted to make sure it was represented in the poster. So Grand Portage Human Services already hosts sobriety feasts twice a year, which is not a direct initiative out of the ARCorp grant or used from the ARCorp funds, actually, but the program itself helps to build capacity around those events. And then the additional Narcotics Anonymous groups, we partnered with Brenda, the co-occurring case manager in PHHS, to host, and the judicial branch to host the first Warrant Resolution Day event in our county, which had one person come to, so we called it a huge success. And then they started working on further plans on their own outside of the work that we were doing under the ARCorp grant. So that's, a huge win also. And then we also used ARCorp funds to provide reflection, treatment, and recovery books to people who are in utilizing peer recovery support services in the MAT program or receiving services in PHHS case management. So they have, more of the tools and resources that they need. And Brenda and Mike, were really well-intentioned about the different books and resources that they chose. We also used ARCorp funds to purchase backpacks that have different assortment of personal care supplies for people who are transitioning into or out of treatment settings, because sometimes, when you're coming in or going out of those settings, you don't have even your basic, supply needs met. So we have those available also. And when we look at sustainability, the ARCorp grant sunsets in August. So we have a few different initiatives that we are also working under in conjunction with our corp. And, when you look at prevention and treatment and recovery, all of these other grants and initiatives, they all are so well connected that, it creates a pretty smooth transition. We have a substance misuse and suicide prevention coalition that started, it was one of the requirements on the work plan for this RCorp grant, and it took 3 years, but we are up and running. In May, it will be a year. And so the group has spent a lot of the time sort of with bylaws and setting up the processes and infrastructure. But now we're moving into cannabis education initiatives is sort of the big thing that we're focusing on next, as well as asset mapping in our community, looking at what are those assets that we have that promote protective factors around substance misuse and suicide. And then under the Minnesota Department of Health Community-Based Substance Misuse and Suicide Prevention Coalition Grant for youth-specific prevention work, we are, Rocio is working to build a youth coalition that will work closely with the coalition that we already have in place. So the prevention initiatives that we create are really youth-driven instead of, grown-ups saying this is what we should do. So we're making progress on that. We also, thanks to all of you, are able to use our opioid settlement funds for further initiatives in the risk reduction area and prevention area. One of the initiatives that are coming up next is a collaborative lockbox distribution between Grand Portage Health Services, Grand Portage Human Services, Sawtooth Mountain Clinic, and PHHS. So we are distributing lockboxes focused towards families with young children or elders in our community who have young children in their household so they can securely store their medications. It also marries well with the cannabis prevention. If people are, recreationally using cannabis, keeping that locked up is important also. Grand Portage Human Services received separate funding, but they're expanding their peer recovery specialists in their organization. And then, what did I miss on there? Oh.
Sawtooth Mountain Clinic received a HRSA Behavioral Health Services Expansion Grant. So we just hired a behavioral health director, and we are soon going to be hiring another therapist, so that will put us at 6 total. And that grant also builds capacity at the clinic for more peer recovery work. So I don't know what that's going to look like yet, but yeah, it's an exciting grant to get.
Yeah, so some of our future risk reduction initiatives will come from some of those funding sources that I cited, as well as some funding sources from Sawtooth Mountain Clinic around sexual health. And then we also have some cannabis prevention funds that we can use in, prevention. When we look at prevention, we sort of don't focus on one specific substance, like the RCorp grant is an opioid response grant, but in the world of prevention, we look at that through a wider lens of, what are the shared risk and protective factors for substance misuse and suicide, and how can we, decrease those risk factors all around. So. You have any questions about that?
Commissioner Sterling.
Thank you, Mr. Chair. I'm intrigued with the lock boxes. How will
Yeah.
they be distributed?
So we are they are mostly going to be distributed through Sawtooth Mountain Clinic, Grand Portage Health Services, and Grand Portage Human Services, and then Public Health and Human Services case managers. I have a sort of draft media release going, and I think, the goal is to educate the community that they're available. They will be offered to people, or people can ask for them, or there will just be the option to connect with me and request one if you don't have an appointment at the clinic or at Grand Portage Health Services. So there will be, it will be through those avenues, but, the real important piece is to let the community know that they exist so they can find them through those avenues.
I was just thinking about different ends of the county, the west end, east end, and then
Yeah,
this area, yeah.
right. Yeah,
We'll look forward to a release of the news then.
yeah.
Mr. Campbell?
Yeah, thank you, Mr. Chair. With regard to the behavioral specialist and the therapist, were those hires as a result of an assessment said we need those positions from a service standpoint? And, or did they arrive at the decision to make those hires due to the grant monies that were available?
We had a substantial wait list at the clinic for people waiting to do a diagnostic assessment, so start therapy at the clinic. And then the most recent community-wide
Community health
assessment, yeah. I think the last couple have identified mental health as one of the top priorities. So taking on a new provider is expensive for the clinic, and so the grant enabled us to hire 2 more and also do some construction to make offices for all of them.
So as a follow-up with that grant money, as far as how long that funding is available, when you create positions, it would make sense that if you're looking at grant money to do, let's say, a study and analysis or whatever in the community to determine need, your experience, given the fact that you have a waiting list, tells you something, certainly. But then if you apply for grant monies, and sometimes there's restrictions with those grant monies, says you can be used in this kind of application. But typically, if positions are funded through grant monies, there's a beginning and an end of that. And so if the analysis that is done by the clinic says that we can fund based upon identified need that is an ongoing, and grant monies can help to facilitate getting the, place, the space, whatever. But that's basically my question, just understanding that analysis and how grant monies are going to continue to fund the position without that burden going back to the clinic.
Well, now that they are hired and as they take on patients, then reimbursements from those appointments will pay for the positions. So
Okay.
the grant helps us, expand the program, and then it will be able to sustain itself through
Right.
patient load.
I can speak a little bit to the assessment process too. So the county and the clinic and the hospital all have different assessment processes on different timelines. So we have one that's very general for the whole county, and Lee is correct, mental health and well-being has come up for the last 2 cycles since I've been here. And the clinic and hospital also do an assessment for healthcare needs specifically, and they just completed that. So there are these overarching assessments, and part of the goal of them is to do exactly what you said, Commissioner Gamble, and guide decisions on what types of services to pursue, what types of grant opportunities to pursue. With something like a provider, there is this expectation that yes, insurance reimbursements and reimbursements in general for this service will help cover some of the cost on an ongoing basis, but the grant funds can help get people to fill the positions initially or to build some of the infrastructure and physical space that is required to add new services into the clinic. And then the clinic on an ongoing basis is looking at, what the fill rates are for those appointments, for those providers, and their finances. And then we're, for the community health assessment, also revisiting that assessment on a regular basis to see if needs have changed. And then both, I know the clinic and then myself in public health with Allison are also always keeping an eye out for grant opportunities that fit with the findings of those assessments. So we're always keeping our eye out and deciding what's worth our time and energy to pursue, given how much the funding is and how long the grant term is. But that assessment really guides what we decide to pursue in terms of additional funding to bring into the community, into our programs.
Thank you for the background on that. The assessment is, of course, a critical part of determining direction. How do we respond to identified need? And when you find grant monies that help you in facilitating that, the fact that part of that assessment, based upon your response, is an evaluation of the fee structure that will help to keep it sustainable, those are all good factors. They don't always work in our decisions, because when grant monies become available, we see opportunity, but we need to look at it in a bigger context, and that's why I appreciate walking through that. Thank you.
Frank, did you have a question?
I did. Just a comment when you talk about the number of community members who are trained in naloxone and Narcan. I know that all the EMTs, certainly, throughout the various volunteer fire departments are trained, as are the EMRs. And that can be a substantial number when you look countywide. I don't know if firefighters are, in particular. I will ask at the next training. But there's no reason why that cannot be incorporated in one of our regular trainings for those who aren't medical firefighters. So I was just going to suggest that that might be an avenue for another expansion. And of course, we all have our naloxone and Narcan kits in the training, and along with the stuff that's on the ambulances. So we also carry it in our jump packs.
Yeah, we identified fire departments as sort of that next phase of emergency response entities to connect with. Fire departments and search and rescue were sort of the next two entities. I think the main barrier has been time and meetings, and to get all of the pieces to fall together for each of those entities has sort of been a struggle, but, we make progress. But if you have an in, I would connect with you.
And Andrea, correct me if I'm wrong here, but we offered this training at a previous emergency services conference, right?
Yes, we did. Yeah. I don't know if it's on for this year, though. No, I mean a naloxone training. I think because it's short, it's hard. The Emergency Services Conference has, when you think about breakout sessions, they're a specific length of time, so fitting them in appropriately. But we have a local trainer. We have multiple local trainers. So typically what we do is we work with higher ed, and they do the monthly naloxone trainings, naloxone and Narcan trainings, in conjunction with their CPR and first aid, or you can do it by yourself or by itself. The naloxone Narcan training is at no cost because we use the opioid settlement funds to provide that to community members. But also the Rob Wells, who does the training at higher ed, he has gone to other specific entities directly to do that training for their employees. So,
yeah, for the fire departments, it would be very easy because we're meeting together for training twice a month, so you can take 15 minutes out of that. It just has to be coordinated with the fire department.
And that would be fantastic.
Yeah, and they all have, of course, their own EMT.
Yeah.
People who could do the training right there.
Right.
So that's just a question of contacting them.
I'll connect with you.
I'll let you know if the firefighters are carrying the naloxone and are trained in it.
Yeah, and if they're not, we have it.
Got it.
Rowan, did you have something?
Frank addressed it. I was just
There we
going to
go.
share.
There. Any other questions? Allison?
Andrea, did you speak at all to our planning efforts around a public health vending machine as a next phase of this work? I know we're still very much in a planning stage, so don't want to put you on the spot there.
No, I did not speak to that. So we potentially have we do have some additional R Corp funds that are not spent across the consortium So, Laura Palumbi, who is our sort of grant director, and I actually know what her role is called, project director, who is now still partially employed through UMD College of Pharmacology. She, when she realized that we had these additional funds, suggested that we work on a public health vending machine, which we had talked about previously throughout the years of the grant, but then decided, you know, since we don't have immediate funding for it, we would sort of put that conversation on hold. And we did the cabinets in the bathrooms here, and then just recently we expanded to the cabinets at the community, or the bathrooms at the community center. So we, over the last month or so, we sort of went through some conversations around this public health vending machine and identified what the potential barriers are, as well as what the, you know, the potential positive outcomes from it, right? So what we decided was that we are going to move forward with the public health vending machine as a pilot program for 1 year to determine, one of the struggles that we had was a location to put the machine, because you have to have dedicated internet, you have to have dedicated electricity, somebody has to sort of oversee the, you know, just the workings of the machine in general, and then somebody has to oversee the refilling of the supplies, as well as the sustainability on the cost of the supplies. So there's a lot of stuff that goes into the public health vending conversation. But a 1-year pilot program that we will present to the building committee, to our goal is to put it inside the courthouse for a year and figure out, you know, what supplies people are using and what they're not using. You know, get some community feedback on those supplies. Are there things that people want versus, you know, what they don't want? While we explore other potential locations, the machine, you know, is not light, but it is movable. We're going with an outdoor machine, so we have more freedom of location. One of the barriers for our community is that there are not a lot of places that are open after 5 o'clock. So trying to find a place where people can access these supplies 24 hours a day has been really difficult. So they make an outdoor machine that is temperature controlled inside and outside. The glass is temperature controlled. We just don't know, from the communities that I've connected with that have the outdoor machines, they've only had them through 1 season. So we're a little bit nervous on like the longevity of the cold weather over a number of years, but you know, it's a pilot, so we'll see how it goes. We have a list of personal care supplies, risk reduction supplies that we will start the machine with in the beginning, and then look for some public feedback on, you know, how we want to change those supplies. But you will get more information after it goes through the building committee.
All kinds of hands here. Frank, please.
Yeah.
And again, from the volunteer fire departments, I believe all fire departments have a vestibule which is open. Okay? You need the pass key to get into
did
where
talk
the
about
fire
that.
trucks and equipment are. But
Yeah.
there is a mudroom, a vestibule there. And they would all have Wi-Fi, they would all have electricity, and they would be protected from the weather and available 24/7.
Yeah.
Just an idea.
And we did talk about that, and I will connect with you on that also. Part of the when you look at planning, like it has to fit, right? So one of the potential locations that we looked at was inside of North Shore Health, because you can technically gain access to that building 24 hours a day. After 10 p.m., you have to be buzzed, 8 or 10, you have to be buzzed in. But when we walked around with the measuring tape to figure out where it might fit, there was really only one location that worked because of how the size, right? So, you know, taking that into account also is. Yeah.
We also want people to feel comfortable using it. So
Right.
if people aren't often accessing the fire halls, you don't want them to feel like they're, you want them to be able to feel a little bit anonymous, and they might not feel that way if it's someplace a little out of their way. I don't know.
Yeah.
I can add one of the things we talked about in making it a pilot is just giving ourselves more time to have conversations with different organizations that could be potential sites. So the pilot would be 1 year on site, but that'll give us a full year, plus the time it would take for the machine to actually come, which we're looking into, I think, the fall at this
Yeah.
point. So we have now given ourselves like a year and a half to have conversations with different entities because there are a lot of logistics to figure out, and we want to make sure that we're not rushing through the process. And if it doesn't work, we haven't said we're going to keep this here forever. If it doesn't work, it doesn't work. But I think we're trying to set it up and be planful so that we can see what works and what doesn't, and then see if there are ways that we want to shift either the location, the supplies in the machine, any number of variables that go into this project could change over time. So that's the rationale behind using this as a pilot year.
Right, and we also because we had talked about this over 3 years, we were reluctant to just say no, right? And Grand Portage Human Services has separate funding to install 2 vending machines that they're working on also. So part of what we talked about was, well, what if they're really well accepted and people are using them, and then people say, well, why don't we have one anywhere else in the county? And, well, because Andrea said no. Didn't feel right. I worked through all my anxieties around the public health vending machine, and we are officially moving forward.
As a pilot.
As a pilot.
Yes, and we're going to keep studying what works and what doesn't so that we can hopefully be as successful as possible in the long term with this.
Nice. Commissioner Gamble, did you have something?
Yeah, thank you, Mr. Chair. So with the comparable communities that you did talk to, what's the longest that anybody has had this provision available?
I don't know, because the only information that I was looking for was if they had an outdoor machine, how it stood up to the weather.
Okay.
So the 2 entities, one, they were 2 public health departments out of Wisconsin. One of them installed theirs in September, and the other one was November. And they had, up to this point, had no concerns. But I don't know the answer to that.
That's the first part of the question, and what I wanted to understand is that in your exploring this is what you've learned, from their experience. That when you start something, obviously, that we haven't done before, we're going to look and find out what can we learn from others that have done this. And they said, well, you don't want to put it outside. We thought that too, or da-da-da. Or we found that this was the type of things that were used most, or da-da-da-da-da, whatever. Anyway, so I guess from our standpoint of just being informed and understanding, it would help to know what other people's experience has been to the extent that they've had it. Because this is a pilot program, we try to position it based upon the information that is available to us, and then we evaluate and see how it works. But if there's something we've learned from somebody else, my curiosity just says, what have we found in that regard? But
Yeah, I think I haven't developed or, put any of that information together in a comprehensive presentation yet. But when we go forward with connecting with the building committee and, the different collaborators that we have, all of that sort of backstory information will be included, because you have to have some context to make a decision, right?
Thank you.
Yeah.
And I'll add the outdoor machine gives us the flexibility of having it indoor or outdoor. If we get an indoor machine, it has to be indoors. If we get an outdoor machine, it can be either location. So that was the reason behind going with that machine over the indoor. And the other kind of, I would say, community that's in a somewhat similar position is Boys Fort. They also received our corp funding and have had public health vending machines for a period of time. So I think that's a community that we could learn more from because they're a little bit further into this process than we are. The only thing I've heard so far is that just having that point person designated to managing the project as it unfolds is really important because somebody needs to be, watching the stock, making and keeping track of the data for what's being used and what's not, and just really taking ownership of it. So that was, I think, the advice I got via Laura, who's the project director for the grant, having also worked with Boys Sport in the past on a similar project.
Yeah, and we've been asking a lot of information from the person who helped get the machines going in Boys Sport. She's been a huge help, even though she's not in that position anymore. She's been a huge help on sort of the logistical side, understanding, the things that you need to think about in advance before you move forward, so.
Great.
Thank
Commissioner
you.
Storley, did you have a question? Yes.
What's the ballpark cost of one of these machines? And is it like the size of a Volkswagen Bug, or is it like the size of a refrigerator box?
No, it's like 35, 42-ish inches. I don't
It's like a
have,
large vending machine.
yeah, I mean, yeah, it looks
Looks like a vending machine.
Yeah, it kind of looks like a snack machine, right? And then, so it's not huge, it just, has to, when you look at potential locations, you have to, because a lot of people suggested outside behind the courthouse, and so, but when I went out there to look, there's not a lot of places that are clear enough that's not blocking a door or blocking a walkway or, creating accessibility issues.
Or snow removal issues.
Or snow removal issues, right. And approximate cost of the machine. So the outdoor machine, I'm just going to ballpark because I don't have it right in front of me, but the outdoor machine includes its own cellular connection and the data tracking app. And it's like just under 9,000, I think.
Yeah.
For the machine itself. So that would be building the machine out. They have to, fit each coil slot to fit the supplies and all of that stuff. Yeah, so that would be the initial cost.
Okay, thanks.
And that will be funded through the R-Corp grant, as well as a bulk of the initial supplies that we purchase.
And I will add that's a part of our sustainability planning, as well as looking at ongoing funding sources for maintaining the supplies within the vending machine, as well as the staffing resources to track and maintain those as well.
Oh, yes.
Hi.
Please, Andrea.
Yeah, I would like to ask, I have two questions for Andrea and Liv. If you can speak about what are the triggers of opioid addictions and substance misuse, and then what does the vending machine offer?
I'm going to answer the easy one first. The vending machine. So for the vending machine, again, I don't have that pulled up, but what we did was we looked at the supplies that Pam had sort of come up with Boys Fort, and then what supplies, from the few different entities that we connected with. So we would be looking at nasal, Narcan. We have some cold weather supplies like hats and gloves, deodorant, HIV test kits.
Pregnancy test kits.
Pregnancy tests, thank you, condoms. All 3 different types of condoms in like a little packet with lubricant, and then we have some snacks. We have Ensure, protein drink, sunscreen,
Fentanyl test kits too?
fentanyl test strips, in packages of 5. What?
Toothbrush?
Toothbrushes and toothpaste kits, yes. Socks. That's all I can think of right now. But there is a comprehensive list that I can share with you and will be included in the proposal to the building committee, you know, sort of that initial round of supplies that we'll be starting with. And what was the other one?
What are the triggers of opioid addiction and substance misuse? Or if you can speak about the triggers. What brings
Anything.
What can bring them onto like feeling into an addiction, or that would like look for recovery, you know, like mental health, violence, is not just recreational choice.
Right. So it's not just recreational choice, but because that is a really big question, I sort of don't know how to answer it right now. I think that, you know, when we look at risk factors, you know, it's having a safe place to live, having people that support you, a welcoming environment, a sense of belonging. Thank you. So I think I just don't know the answer. I can't say it right now.
I think it's just not a simple answer.
Yeah.
Really. So that's why often we'll talk about risk and protective factors. So what are the things that makes it more likely that someone will misuse substances and perhaps face addiction in their life? And what are the things that would protect against that? So it winds up being these two kind of big laundry lists of what you can promote to make it less likely that a person would misuse substances and what you can try to prevent. And so another thing that you may have heard about is this idea of adverse childhood experiences. So there are things that might occur early in one's life that would make somebody more likely to experience substance misuse later in life. And so when we talk about trying to reduce adverse childhood experiences or promote positive childhood experiences, that's kind of looking at prevention from the very beginning of a person's life. And we could absolutely provide more resources into what those lists are. I don't want to try to brainstorm off the top of my head because I don't want to miss some important factors, but we can absolutely provide more context to the board and to the public on that.
Thank you. I was struggling there.
Thank you. Any other questions? Thank you very much.
Thank you very much.
Difficult work. A lot of emotions, a lot of assumptions, a lot of stigma, and so I just really appreciate all the work that's being done in the community and all the partnerships, and you know, it takes a village, for sure.
Can I add one more thing is that, you know, coming out of COVID, we saw at multiple levels that substance misuse was a worsening issue. And so I actually can frame this up as something that's been on, you know, mental health and substance misuse has been on our health assessment as a priority area for a very long time. But coming out of the pandemic, this also became a community recovery issue. And I say recovery, and in this sense, I mean, what do we see coming out of this global health phenomenon locally? And so this is one of the things we kind of shifted internally to focus on coming out of the pandemic. We were not doing prevention work during the pandemic. We were doing COVID response work. We were hosting vaccine clinics. We were doing contact tracing. And this has been a big shift in our work as a department. And I just think it's important, as we're on the 5-year anniversary now, to kind of reflect upon the fact that this is one of those public health issues that we saw really intensify coming out of COVID. And so this is one of the ways that we've been able to really address that in our work as a team. So,
yeah, it's well said. Also, just thinking, I guess, putting it in context of COVID and the isolation that we all, or many of us, experienced or felt, and maybe continue to even after 5 years, and just how that is a risk factor for substance use and misuse, not having that sense of belonging necessarily. And so I see the ties there pretty strongly too.
Thank you, Commissioner. Thank you, Grace, for those closing words. It's really beautifully stated. Thank you to our presenters. I think it cannot be understated how significant it is, our work in partnership in this area, and how much capacity we've built in the last 5 years, 4 years under this grant. As Grace said, we were doing very little substance misuse prevention work as a department prior to 2020, and now we have 2 staff essentially dedicated to this work, and that is significant. And the amount of community capacity that we've built through the naloxone trainings, through Arrowhead, our efforts to saturate the community with these life-saving medications is really big. So thank you all for being a part of this work.
You know, one last thing that I'd like to share, and I think I have with this group, I don't recall, and you're probably more privy to it than I am, but we hear so much about adverse childhood experiences, and I really believe that there's a lot of benefit in addressing those and trying to prevent those. But then I also heard a little more recently, I guess in the last 6 months or something, about benevolent childhood experiences and the impact those can have on everyone, children, I guess, and how that can either compensate or help, heal from adverse childhood experiences, and just how powerful those are. And so creating sense of belonging or community with youth and just groups in our community can be extremely powerful. And I'd like to lean into that a bit more if we can in our work. And I know that we are, but we can never do too much of that, I don't think.
Yeah, and there's also, conversations around benevolent adult experiences, and sort of, you may have had adverse childhood experiences, but as an adult, what are those benevolent experiences that can help to, build up your resiliency and your well-being? So, as we look at our asset mapping in our community through the coalition, we a large focus is on youth, because you're looking at that upstream prevention. But, when you look at prevention, you really have to look across the age span. So, talking about those benevolent adult experiences is important too.
Yeah. And
so thank you.
That could prevent, benevolent adult experiences could prevent adverse childhood experiences. And, we can have a positive circle instead of always a negative spiral. But we can spiral up. Is that a thing?
Mm-hmm. Yeah. I'll also make a pitch for our prevention coalition, which I don't want to take Allison's invitation away from her. I know it's something she's going to integrate a little bit later into her director's report. But we have board members participating in so many groups and committees, and one of the groups that we are hoping to get representation on is our prevention coalition, which meets every month and dives deeper into the topic of things like adverse childhood experiences or benevolent childhood or adult experiences, and tries to really work through what some next steps would be. And it's across sectors. We have representation from faith communities, churches, schools, nonprofits, and so we're hoping that we wind up with a board representative who can continue to report back to this board on what it is that's happening in the realm of prevention. So Allison will talk a little bit more about that with her report, but just wanted to throw a pitch out there for the fact that this work continues and that we're not doing it alone. So
thank you. All right.
Thank you.
Thank you. Have a great day.
Thank you all.
Thank you.
And that does move us to our director's report here. Includes staff updates and agency updates.
All right. Good morning.
Good morning.
Since our last meeting, we have brought on one new staff within the department. Sarah Eisenreich started as our mental health coordinated crisis response worker. Sarah will be on the agenda next month for an introduction, so y'all will get an opportunity to meet her and learn a little bit more about her background. She is deep into the onboarding process, getting set up with our department-wide trainings, and also learning our new electronic medical record that we have invested in for crisis response and substance use disorder treatment services. So very glad to have Sarah on board and to have someone in that position as we're continuing to move forward with formal delivery of those services through a DHS grant contract. Also, in staffing updates, we conducted our second round of interviews for the adult and home and community-based services supervisor following Martina Johnson's resignation and transition to the Department of Human Services, and hope to have a hiring decision either before our April Public Health and Human Services Board meeting or at one of our regular board meetings in the weeks ahead. We conducted children's mental health case manager interviews last week and are expecting to make an offer this week. And the only other vacancy right now is within children and family services. We had to repost a case manager position after that offer was extended and then declined. So we are reconnecting with candidates for interviews. We do have a few new candidates to consider for that position as well. So starting to see a little shift in the volume of applications coming in, which is positive. As always, I've included an organizational chart in the agenda materials to reflect those changes since our last meeting. Any questions on staff updates before I move into agency report? Okay. Well, I would like to start by acknowledging that March is National Social Work Month, and would like to read for you all a proclamation from the National Association of Social Workers. I'm going to skip through the whereases as it's very formal. I'll read the first one and then I'll eliminate the rest, hopefully not too awkwardly. So again, this is from the National Association of Social Workers. Whereas people have entered the social work profession for generations because they genuinely care about helping improve the welfare of people, families, communities, and our nation, this year's Social Work Month theme is Social Work, Compassion, and Action, and embodies the fact that social workers go through years of education and training so they have the skills and expertise to transform their care for others into action that brings positive results. The social work profession has worked for generations to improve living conditions in our nation, with social workers successfully pushing for Social Security, a 40-hour work week, Medicare, and minimum wage. Social workers have helped this nation live up to its values by successfully advocating for equal rights for all people, no matter their race, sexual identity, gender expression, culture, or religion. Social workers follow a code of ethics which sets as the primary mission of the social work profession the enhancement of human well-being and meeting the basic human needs of all people, with particular attention to the needs and empowerment of those who are vulnerable, oppressed, and living in poverty. The social work profession is one of the fastest growing professions in the United States, with more than 800,000 people expected to be employed as social workers by 2033. Social workers in all parts of our societies, including schools, social services agencies, veteran centers, and government, are helping people, family, and communities secure services and policies that they need to thrive. Social workers are at the forefront of pressing issues our nation is addressing, including increased needs for mental health care, especially for children and adolescents, and substance use disorder treatment, and increased economic and political division. Social workers are one of the largest groups of mental health care providers in the United States and are pressing for a social work interstate licensing compact that will improve mental health care delivery in our nation. Social workers help protect millions of children from abuse and neglect, provide services and support, which helps strengthen families that are under stress, and help create new families through adoption. Research proves that the presence of social workers in schools, hospitals, and assisted living facilities improve education and health outcomes and quality of life for students, patients, and residents. Social workers continue to stand ready to assist our nation in overcoming present and future challenges, including ending gun violence, improving health care and mental health care for all, and urging lawmakers to adopt immigration reforms. I want to take a moment to recognize the social work professionals within our organization who show up every day, every month to do this tremendously challenging but meaningful work. Also to acknowledge that we aren't alone in delivering social services in this community. We rely on a network of local and regional social service providers, including at our schools, hospitals, tribal human services, and state-operated facilities as well.
Well, it seems appropriate we do a round of applause.
All right. So thank you for letting me take a moment to read that and just acknowledge the diverse range of services provided by social workers, both in our community and in our nation.
Thank you.
In terms of work going on in the department, we are conducting some social media outreach on Medicaid and potential cuts to Medicaid services, how that would impact the Cook County community locally based on the number of individuals who are enrolled in Medicaid services. Andrea Tofty, our public health educator, who is working specifically in emergency preparedness, infectious disease control, and healthy housing programs, will be representing the department at the LPHA, or Local Public Health Association Department Day at the Capitol later this week. So excited to hear more about her experience engaging with lawmakers down at the state capitol. Our statewide health improvement coordinator, Christina Matson, attended a regional food forum within the last month to do some networking with other entities in the region who are working on food access work. May is coming up, which is a busy season for Christina and her work in terms of the Safe Routes to School and bike safety work that she leads with other community partners. And she's also participating in a regional lactation summit in May. So just a snapshot at the diverse range of responsibilities within Christina's scope of work. Leaders from our department are participating in the visit with Senator Housechild later this week. So again, looking forward to do some advocacy around the areas that are identified within our community health improvement plan, as well as some of the legislative priorities laid out by the Association of Minnesota Counties, Local Public Health Association, and Minnesota Association of County Social Services Administrators. I want to give you all a heads up that looking ahead to the April meeting, I will be out of the office and will have to miss our meeting. So I'm in conversation with our leadership team as well as Chair Mills about planning for a more condensed board meeting in April. My plan at this point is to forego any staff presentation, and I don't foresee that we'll have any items for board action that will be pressing in April, but if so, I will work with Rowan to present those at a regular board meeting. And I will, in lieu of a director's report, submit a written report that will cover any staff and department updates. So feel free to reach out to me if you have any concerns or feedback about that plan for our April meeting. Lastly, as Grace indicated, if you're feeling really energized and excited about prevention work, we are seeking a commissioner representative for our local prevention coalition. And I don't know how you'd like to approach that, Chair Mills, if you'd like to have a discussion now and take action, or if you would prefer to have some time to consider, reach out to me or another member of the public health team. Our coalitions are open, so you'd certainly be able to attend, barring any, group, too many commissioners attending the open meeting law violation. Thank you, that was escaping me for a moment. If maybe one or two of you were interested and wanted to attend the coalition to get a sense of what they're doing, that would be an option as well. They do meet this afternoon and monthly on the same date as the Public Health and Human Services Board meeting. That meeting is held at Cook County Higher Education, but we also have hybrid arrangement available if you prefer to attend virtually.
What time is that at?
Let me pull up my calendar.
Mm-hmm. Do I see movement over here?
It's from 1 to 2:30, so it conflicts with the Personnel Committee, which would be an issue for those commissioners representing on that committee.
I saw movement over here.
We're both on the Personnel Committee, so.
Please.
Thank you. Can you give, and maybe it's just me that doesn't have a clear understanding of the role and responsibility as far as our involvement, so if we have an overview of that, that would be beneficial. And again, it might just be me that is not aware of the nature of that coalition.
Thank you for your question, Commissioner Gamble. I would happily send out the bylaws and meeting charter to the group so that you have a sense of the mission of this committee.
And I think it might be beneficial if we had that and then looked at schedules and alignment prior to making a decision today.
Yeah. Absolutely, absolutely. And then as with any other commissioner appointee to a committee, one of those primary functions would be bringing those updates back to this board to be able to share with the other commissioners and the community your perspective on the work that's happening within that coalition.
And probably add it to our committee reports there.
Yeah.
But that would be, yeah, that'd be great to get that info and then we can discuss it at our next meeting.
I'll follow up with that after our meeting.
Thank you very much.
Absolutely.
Oh, yeah, we could do that for April.
There you go.
Well, you're not here, we can make that decision.
I
We can at
trust you
least
all to
talk
make
more
a
about
sound
it.
decision around commissioner representatives, so yes. But I will follow up with the charter and a summary of the work of the meeting. I believe that the Prevention Coalition is on iCompass, along with the
Oh.
other
Oh, okay.
committees and coalitions. We're working to move all of
Great.
the groups that we convene or lead as a department onto iCompass to
Excellent.
really increase that public awareness and transparency around our work. So I can point to that. And then I see I have a message coming through from Grace. Andrea has also indicated that she would give a one-on-one orientation to the commissioner who attends regarding the Prevention Coalition. So you'd have the opportunity to meet with Andrea in advance to learn more,
Yeah,
get caught up.
great, thank you. And thank you for.
Andrea.
Yeah, thank you, and thank you for the ask too, right? I think it's really important to have that, to identify the group and just the benefit of having more representation as well as just the lines of communication there, participation.
And that's it for department updates. I can just give a brief overview before we move to item 5, items for board action on the grant agreement with the Department of Employment and Economic Development. So this grant contract, item 5A, we're seeking that the Public Health and Human Services Board approve and execute the grant contract with the Department of Employment and Economic Development for childcare economic development work within Cook County. This is our 3rd year of receiving grant funds from the state. I expect that Commissioner Storley will have some updates to share from the recent Child Care Coalition, so don't want to go too deeply into that. I will also mention that Nancy was on the radio recently, Nancy Deming, our Children and Family Services Supervisor, who is still carrying the bulk of the workload around our community child care initiatives. Recently recorded an interview with WTIP that's published on their website. It provides a great overview of where we're at 3 years into this pilot project of providing essential supports to our child care community and providers to help address the gap in available slots for families so that they can work.
Any questions around this request? If not, I'd entertain a motion here.
Mr. Chair?
Please,
I'd
Commissioner.
like to make a motion to request that the PHHS Board execute the grant contract with DEED for the Child Care Economic Development.
Thank you, Commissioner Sullivan. We have a motion. Is there support?
I'll support.
Thank you, Commissioner White. We have a motion and support. Further discussion? Hearing or seeing none. All those in favor?
Aye.
Aye. Opposed? Motion passes unanimously. Thank you. Very good. Well, that moves us on to our committee reports. Start with the Active Living Steering Committee. Commissioner White.
Okay, look at my notes. Active Living Steering Committee. I missed that.
Okay.
There's some conflict with, I'm sorry,
No problem at all. Anything from AEOA?
no.
Okay. And then AHA.
Yes. They are now past signing the contract to have the building. So they've got that ironed out. So they have a secure place to conduct the services for emergency mental health for kids. So that's been done. And then they also, what was the other thing? Oh, no, that was the other place. That was the big thing.
Okay.
That was really the big thing. It was primarily Zoom and that's it. That's
Yeah.
not a very good one, but there was not a lot of new things that happened.
Yeah, well, having the building is pretty key, right?
Pretty key. Lots of hours went into that,
Yeah, oh, yeah. Well, I think it even started,
way before me.
yeah, yeah, it's familiar to me, so I'm glad that is ironed out.
Complete,
It's-
yes.
ARC, Arrowhead Regional Corrections, Commissioner Gamble.
That's coming up this week.
Thank you.
Did
Oh, please.
we talk about what we did at the last one? I don't
Well,
know.
it
But I
would
will
not
say
have
that
been-
we toured the meat processing place.
Oh,
Good food. That's all I've got to say.
that was something different than my previous
Yeah.
service on that committee, that we're always talking about pigs. And so I was impressed with the leadership, the gentleman that's the head butcher there, and he came from Grand Rapids, Minnesota, and he said that he was taking a job at NERC, and he was going to teach inmates how to use knives. So that was his exact quote.
Low
But
stress, yeah.
yeah, well-run facility, and it gives an option for the public to be able to access, meat products, and they do a lot of processing for farmers. So I can tell you, in my experience working with NERC, that the legislature has always been impressed with the operation there, and the farm nature and creativity that goes to encourage and help people to get back into society. And so it's a very good program.
yeah, I happen to know too that there are no longer, my understanding, and things could have changed, there are no longer butchering schools in Minnesota. So it's only on-the-job training, so those skills are particularly, I think, useful
Yeah.
yes.
And I just happened to randomly hear on the radio that there is a push, we're going to have a butcherman shortage
Yeah,
coming up. So,
yep.
I think we got a lot of shortages in a lot of areas, and because of the nature of the demographic, it's true, but it's, anyway, so, yeah, that and just the statistical overview that we have, and we have a very good statistical analysis. She does very good work and keeps the board informed, so that the information and decisions that are made with good information, so.
Great.
There's been a lot of transition in individuals, but individuals that I had the privilege of interviewing in my first term that are now in positions of leadership. And so good people, and it's neat to see that those people have moved up in the organization and
Yeah,
well respected, so.
a lot of value in that continuity
Yeah.
too. That's excellent. All right, Child Care Solutions Subcommittee, Commissioner Starling.
Thank you, Mr. Chair. Yes, we did meet last week. We hadn't met in a while, but things are moving along now, and just want to remind you what the committee's purpose is for childcare: to support and grow the workforce in Cook County and Grand Portage, and then to explore ways to make our wage enhancement program sustainable for providers and for childcare more affordable for families. So we just approved the $385,178 monies that will go toward all of these programs and more that I just mentioned. And updating on the providers, as of February of this year, we have 27 providers. We have 149 licensed slots, and 82 children that are being served, and Cooperation Station is temporarily closed right now, but they're working on getting that going again with a group of people. The future of this right now, we agreed, is maybe to go out into the community a little bit more to find out with the businesses and lodging community, what are some of the non-traditional hours that their employees have that would affect the childcare. And what is needed there and where are they located? And so that's kind of, for me in the West End, to do a little more digging into that, just to see, what those businesses would need. And then also, transportation and geography is a barrier to a lot of families also, and I don't know what we could do there, but it's something to discuss and to look into. And then with our new apartments and developments, perhaps would there be some type of childcare within the apartment development? And we've heard a little talk that possibly will be in one development. So, as we progress into other ones, if that is part of the developer's wishes to be able to do that. I know with Birch Grove having the modular homes behind the school, that's a perfect setup for folks to maybe be involved in something there if we can find another room. Right now, we have great success with babies up to age 3 in one room, but we'd have to see about that for more involvement, in the West End. But anyway, there's always good topics to talk about, and fills up our hour and a half really fast.
Yeah. Thank you. Let's see, Community Health Board, we have not met since our last meeting. Moves on to the Local Mental Health Advisory Council. Hannah.
Okay, yep, we met March 11th, a week ago, and we have a big, I was reelected to be the chair, and the vice chair is, I forget, who?
I believe Heidi
Oh,
was
Heidi,
reelected.
yeah, Heidi will be the vice chair, which was good. And we have talked about, there was a regional behavioral health needs assessment that took a whole year, and the report is available online. It's the Region 3, there's an executive summary, combined summary, and we're in it, plus northern Minnesota and several different communities, and talking about what is available and what we need for mental health and children. And it was really very, I think it was about 50 pages. So I'm not going to go through it, but if anybody has the desire, it's available online. And would that be going to our site?
Yes, so the full report and executive summary were included in the Local Mental Health Advisory Council meeting materials, which are publicly available on the website meeting portal. You could navigate to the Local Mental Health Advisory Council and find a copy of that report. If anyone would like a printed or emailed report, I'm happy to support that as well.
I think that was our main discussion, it was a big report, and we talked about it a lot, yes.
I'd like to add to that, because Brittany Anderson from Grand Portage, her suggestion was that Cook County should do their own, because she wondered if there were Native kids that were actually involved in this initiative. And because when areas, can't read my writing, urban areas have many needed resources in place to offer them, but we here in Cook County we don't have the same assets available to us. And from Allison McIntyre, she said, the hub was ID'd as an asset for mental health services in Cook County. I wrote that down.
Yeah, I thought it was noteworthy that that was named as a particular community asset for that cohesion and community building that's so important in supporting resilience and recovery. While some communities have drop-in centers as a part of their mental health service delivery system, that's just not something we have here, but the hub is a close approximation.
And to draw people in, they have really good popcorn all the time.
And other good food.
Right, but any time of day they have popcorn.
Commissioner Gamble.
Yeah, thank you, Mr. Chair. That report that's available, that's an assessment that was done locally. Has a similar study been done regionally or within the state. And the reason I'm bringing it up, it might be helpful, especially for the community, but I think as decision makers as well, if the findings of that study could be discussed as to what we learned from it and how it compares to see if regionally or, within our county, how we are comparable and what some of the, conclusions or assumptions we could make based upon the findings of the study in that comparison. So any time that we're doing a study, as we heard this morning, it informs the direction we choose to go to address the identified needs, and it'd be helpful to understand it in a context that has some comparables, because there might be some things that come in a rural community like we have with all of the accessibility to things in nature and stuff like that mitigates some of the issues that you don't get in an urban community. But I think understanding those findings and using some comparables and then our plan of action would be a good discussion.
It's actually vice versa, though. This was the regional study.
This is the original.
And
Okay.
we need the local one, or at least Brittany was suggesting it.
The question, yes.
Yeah.
We
Do
were
we have
part
a
of
local
it.
one?
Yeah,
Okay.
there were no big urban areas, I don't think, unless maybe Grand Rapids would be the biggest, but.
I think Duluth
Oh,
is
Duluth,
likely the
okay,
largest
Duluth, yeah.
metropolitan
Okay.
area covered in the survey, and it was the Arrowhead Behavioral Health Initiative region. So that's the counties and tribal nations within the Arrowhead of the state of Minnesota. And I would say the closest equivalent that we have on a local scale would be our community health needs assessment that Grace mentioned this morning, which also identifies mental health and resources for well-being as a primary priority.
Yeah.
To your point, Commissioner Gamble, something that I shared in the meeting that I thought would be really interesting to look back at is the assessment that was conducted in 2017. So when I was brand new in the director role, a regional needs assessment study had been conducted by the University of Wisconsin-Superior, the same entity that conducted this research and prepared the report. So from my perspective, I think it'd be really interesting to compare those two and see what has shifted, both in terms of resources and
Sure.
in needs over
Yeah.
that period of time regionally.
Yeah, thank you.
Thank you.
Yes, please.
That's all.
Oh, okay. Thank you.
Well, I could say one more thing.
Sure.
The very end of the report also commented that individuals can help other people by phone calls or helping people that might need something, and just, it doesn't have to be done by only professionals, but community
Reach out and call someone.
health needs are, can be done by a lot of people. So that's good to keep, and I think we do have that here a lot, too.
Yes, we do have a strong community and strong sense of community. Restorative Justice Committee, Commissioner Gamble.
We meet this week. We
Okay.
did the initial meeting. I don't know if we had the review on that, but this was our first, get-together the last time we had met. So basically, it was getting to know each other and the purpose. And when we're at the public safety at the AMC legislative session, restorative justice was the primary focus of our discussion in that. And the gentleman that had been the presenter there had been a presenter up here with our restorative justice, but that was before I had been here. But certainly a lot of discussion and how we can maybe set up some regional centers and things to deal with some of the issues that allow us, with the whole concept of restorative justice, to not make it through the judicial system as far as penalizing or through the typical court approach, but trying to restore through a conciliatory approach. And so that was, it certainly is a good concept and a lot of discussion that just says, how do we do this, and the results that we can measure when we see the people that are the perpetrators and those that are the victims come together and have those discussions. And that's just a healthy thing. Everything's about relationship, and so it's very good. But we have that meeting this week.
Okay, thank you. Council on Aging, Commissioner White. We already did that, didn't we?
Yeah.
Yeah.
David and I were both there. We know what's going on. No. David had been invited to come to hear about what the Council on Aging is, and so they gave him an overview of where they were a few years ago and how they were structured and how they became a very strong working board and some of their challenges and what they offer. They were very appreciative of his attendance, and they are still seeking a grant writer. So, and they're essentially living on the edge at this moment. I mean, they have plenty of monies, but they've got to secure some funding to continue to go forward. Their reserves are all good, but you can't live on your reserves forever. You have to have money coming in, as we know. So they're going forward with the fundraisers, and they have a great many donations every month from citizens. So it's a good group. And they are a real asset. And they still do have good popcorn.
Yeah, we're hoping to get them on the committee of the whole
Yes.
agenda in the not too distant future here. And the number that stuck out to me was they need, I think, $100,000 by August for operations. I was like, oh boy, that's a big lift. But they have done it before, and they are doing, like you said, a lot of fundraising and looking for the grants that are out there. But it is very challenging. A working board is very admirable, not always the most sustainable, and especially when you're talking grant writing. That's next level challenge there. So, but we'll discuss more, I guess. Hopefully, April's committee of the whole. Emergency Preparedness Committee, Commissioner Sullivan.
Thank you, Commissioner. So as we think about emergency preparedness, one of the concerns that we have community-wide is as our fire season approaches, and we have questions about U.S. Forest Service personnel and their availability. There are lots of emails and phone calls that are coming forward about concerns. How are we going to manage a potential fire this spring? So I just want to acknowledge that we've received a lot of inquiries and that we are going to address those, and I imagine we'll be going around the county doing a lot of emergency preparedness events again this year. Important to note that Senator Hochschild and Representative Scraba will be here this Friday, and one of the things from an emergency preparedness standpoint that will be shared, and I believe Administrator Watkins and also our Director of Emergency Management, Mike Keyport, will be talking about the impact of federal funding to emergency management and also the need for some small weather radar unit somewhere here in Cook County. But they will be talking to our representatives and Senator about that. And there has been a Senate bill that has been introduced to address part of this, so we will keep our eye on that and keep our community informed.
Healthcare Planning Committee, Commissioner Storley.
We have not met.
Okay. And NACO, anything there?
Right into that, yes. Well, they had their big conference out in Washington, D.C. I chose not to go this year because of things that are happening out there. I felt I could be part of the resolutions and continue with my Zooming. And but just a brief little update on the topics of the conversation and workshops that they had. One was on mental health and well-being from crisis to solutions. Protect funding for core local public health and preventative programs. County role in food systems, and then dealing with federal regulations on mandates, funding, constraints, and then administrative burdens with all of these regulations. So there's always, the forefront sentence with all of us is looking forward with a partnership between the federal and the county. But as a result of our discussing all of this over the year, then what happened with the federal government hinting that there might be some cutbacks with Medicaid, we sent a letter. I'll just briefly talk about the letter. It's a bipartisan membership from organizations all across the United States with governors, state legislators, cities, and counties. We're committed to working collaboratively to strengthen the Medicaid program so that states and localities can continue to meet the needs of the residents effectively. We write to express our proposed changes, possibly to Medicaid financing and requirements that would significantly impact the state and local budgets, healthcare infrastructure, and millions of Americans who rely on this program. It's a federal, state, local, and partnership. We feel that the policy changes that mandate specifically eligibility requirements and changes in fiscal makeup of the program threatens the Medicaid effectiveness and reduces the state flexibility in program design. Some changes have costly implications, leading to significant coverage losses for beneficiaries and increased medical debt and unclear long-term savings. The Congressional Budget Office estimates that half of those losing Medicaid coverage under such changes, the folks would become uninsured and leading to higher debt. So we look forward to continuing our work together as intergovernmental partners to enhance the Medicaid program and ensure that states and localities can effectively serve our residents. That's the letter we sent. So we'll see how that's going.
Fingers crossed.
Yeah. Thank you. Thank you.
Northeast Minnesota Office of Job Training, Commissioner Gamble.
The first meeting that I would have been able to attend happened during our legislative session, so my first opportunity to re-engage with this organization will be Thursday.
Okay. Let's see, North Shore Collaborative, we have not yet met. PHHS Advisory Council, Frank.
Thank you. At our last meeting earlier this month, Allison gave us a briefing on the impact of Medicaid to the county, and it was substantial. 1 out of 4 county residents are receiving Medicaid assistance. A total of $7 million for the county, over $1,200 per capita over the entire county. And in Minnesota, Medicaid's the single biggest payer of health care costs, even bigger than Medicare, which was a surprise to me. Therefore, changes in Medicaid, substantial impact, and we don't know what it is yet, and that's why Allison is keeping such a close eye on this. We also discussed the proposed amendment of bylaws, eliminating a 1-year requirement for vice chairman. We're going to take that up at our next meeting. And in association with that, we're planning a recruiting drive to broaden advisory council membership and participation. Bylaws allow between 6 and 25 members. Currently, there's about 12 members, half of which are provider members. The bylaws also provide for the fact that 1/3 of the members of the advisory council shall be representatives of those persons receiving services provided by the Public Health and Human Services Board. I believe there are like 0 of those at this point. In addition, they must include representatives of private providers if such providers exist in the county. I don't think there are any physicians, but I know that there are a lot of allied health professionals in the county, and that's one of my suggestions as we're doing our pre-meeting brainstorming is to is to target the allied health representatives for membership on the advisory council. There's also a question of discussion as far as the budget goes about why mental health placement expenditures at state-operated facilities are so variable. $40,000 in 2022 to over $480,000 the very next year in 2023, which makes it extremely difficult to budget for. And that, of course, is because we're dealing with very small numbers, but high impact for each additional person served, and somewhat unpredictable. And finally, the Public Health Fund Public Health Fund Subcommittee will be receiving reports from grantees from last year's grant cycles coming up in April, and I'll be happy to report on that next meeting.
Let's see, Food Access Council, I think I maybe already reported on this. We had a small kind of working group going over mission vision and what the group is hoping to be there for. And I guess I'll just keep reporting as information comes in. But basically to provide affordable, healthy food for our community is the long and short there. And this council is hoping to network the players that can enable that. Last thing is the good of the order. Anything, Allison, please?
Something I didn't mention in my report that I'd like you all to be aware of is that we were invited to participate in a healthcare assessment action planning process with North Shore Health and Sawtooth Mountain Clinic. So we have staff that are a part of 2 different working groups that are tasked with improving healthcare access, communication, coordination across health and social services agencies within our county. Those priority areas are streamlining care coordination and documentation processes and developing a communication plan regarding health resources. We'll look forward to sharing more about that as it unfolds.
Only other thing I'd add is it's my daughter's birthday today.
Hey, happy birthday. Does she like cake or pie or ice cream?
Yeah, I think she likes it all.
Oh, okay. Yeah.
Just like her dad.
Yeah.
But otherwise, we've come to the end. We are adjourned here. Have a great day, everyone.
Where's food that we bring supposed to go? That food,
Oh, for,
the drive.
oh, in,